Some of the questions that I get asked the most frequently is, what about the patient engagement, and what about the patient giving permission to have their information move electronically in an HIE environment? We started off many years ago talking about this, and it's still being talked about and referenced as consent, patient consent. But my staff in the Office of Health Information Integrity have been working with a number of our HIO partners, and we have realized that we really want to change that phrasing, and we would like to address it more simply as patient permission. So we've been working with some demonstration projects. As many of you know, Cal-OHI has legislative authority for conducting demonstration projects, looking for that perfect spot between opt-in and opt-out, where we can balance patient access or patient security, the confidentiality of their information, with the access that's needed for the right patient, the right information, the right time, for the right reason, to the right person, for the right use. This particular panel is going to talk about the experiences of those demonstration projects, and the young lady immediately to my right has become a tremendous friend as well as one of my staff. This is Karen Baruff, and she is the project manager for the OHI Health Information Exchange demonstration projects. She's going to introduce you to these other folks, and we're going to learn what we've learned about that ever elusive patient consent. Thanks, Karen.
Yeah. So when I was asked to lead the panel discussion on trust, and I do say asked, I didn't hear you. I was asked to lead this panel discussion on trust, and as I just said, I used the term asked very loosely. My first thought was, okay, trust. And then I started thinking about what trust means. And, you know, we hear the word trust a lot. We've already heard it a few times today, and it's used in so many different contexts. But you know, like I said, as I started thinking about it more, I thought, what does trust really mean? And more importantly, how do we make it into something that's a little bit more tangible, something that we can really measure? Through the demonstration projects, as Pam just described, we found that trust is critical to making HIE successful. Patients have to trust their providers. Providers have to trust one another, and again, we've already heard about that a little bit today. And we all of us stakeholders have to trust our government entities. And because trust was such a fundamental theme to the demonstration projects, I really wanted to explore that, not just at the HIE level and with our HIE partners, but more at the ground level with our participants that were making it happen. And so that's why I invited these individuals here. They're experts in what they do, and like I said, they're at the ground level making it happen and engaging patients to really build the trust that's so critical to what we do. So we have Dorothy O'Hagan, Director of Health Information at Rady Children's Hospital. Rady Children's Hospital is a participant in the San Diego Regional HIE. We have Vic Singh, Behavioral Health Director from San Joaquin County. And we have Becky Shoemaker, Project Manager from Santa Cruz HIE, also a demonstration project participant. And we've already had the pleasure of meeting Dr. Mahdi from Riverside Physicians, and they are a participant in Inland Empire, as we heard earlier. So my first question, I would like each of the individuals to talk a little bit about the patient permission process, and I want to thank Pam for really introducing that. We've talked a lot about consent and what that means, and how do we engage patients in the process. And And it is a process. It oftentimes becomes a burdensome process. We talk a lot about the administrative aspects of engaging patients. But what I found through the demonstration projects is our participants are finding ways to move beyond the process and educate and engage patients. And these individuals are doing that really well. So I'm just going to ask each of them to talk a little bit about the process at the organizations and talk about how they are engaging patients to really get past that and build the trust of their patients. So, Dorothy, will you start?
So, as Karen said, I'm from Rady Children's Hospital in San Diego, and she says, I like how she said she was asked. I was voluntold about 2 years ago to oversee the HIE steering committee at Rady Children's in San Diego. To let you know a little bit about our organization, last I heard, we were the largest pediatric hospital west of the Mississippi. We have over 449 beds and take care of about 95% of the pediatric population in the San Diego County area. We have 5 hospitals within a hospital where we take care of NICU and pediatric patients in San Diego County as well as South Riverside County. So we started on our endeavor with health information exchange through the Beacon Project in San Diego, which now is transitioned to a nonprofit, San Diego Health Connect, about 2 years ago. And so while we were working on the patient consent piece, our integration team was working on ADT, lab, RAD, interface, and all that. But the question came up, opt-in or opt-out, and let me tell you, as you all probably would imagine, opt-out, that just sounds so good, so easy, much easier to accomplish the success rate versus having those patients, in our case, their parent or their proxy, to opt in on their behalf. Because with an opt-in model, there's more education, and we really want them to understand what they are saying yes to. So through a fairly aggressive training campaign, not just for our clinicians, but our patient access representatives, with training, scripting, really helping them understand the why behind the what, we went live with a pilot in June of 2012, even before our ADT interface was live, just to start building the platform, and found amazingly that our families weren't questioning. It was more, isn't it obvious? If I can get my bank records from my phone, if I have a critically ill child and I'm on vacation, I expect that that emergency room provider would be able to access my child's records. So there was a little bit of conversation about advocacy and really what's best for the patient. That's been the platform that we've used. So since that initial pilot, we've consented just over 211,000 patients with a denial rate of about 1.7%. So we're really excited that our families are engaged and eager, and it's less permission, if you will. Yes, they're educated and they're aware, but they're also already expecting it when we explain the details to them.
Becky, can you talk a little bit about the environment in Santa Cruz and the processes that your providers are going through?
In Santa Cruz, we have an opt-out, meaning everybody is in the exchange unless you explicitly opt out. We didn't have a whole lot of issues with trust among the physicians. We have been in operation for over 16 years. The physicians already trusted each other and they entrusted the community. And the patients have a high level of trust with their physicians. What we discovered when we went out there and were doing education and talking to the providers was the exact opposite. They were concerned, what if my patients opt out? Why I'm not going to get the information that I need? They've been used to the HIE, they've been used to the longitudinal record, and being able to have quick access to that to treat their physician, to treat their patients. So when the idea came up that patients would have to, if the California adopts a model where patients have to explicitly opt in, there's great concern there. They think that they're going to have more difficulty. So we had a head start on it. We didn't have to go out there and build the trust between the physicians. So the process was easy to get the patient's consent and the physician's buy-in. The difficult part is the administrative end. It's still very much a paper process to get patient consent. You have to have a paper form. It has to be scanned. The EHRs are not embedded with the consent to feed into the HIEs, although we are working on that. We have a group that is completely electronic, and we're working on that consent to feed right into the HIE without paper, electronically capturing consent. So we're excited about that.
And Dr. Marty, can you talk a little bit about Riverside Physicians? I know you touched on it a little bit earlier, but can you go into a little bit more detail about the process and what your physicians are doing to engage patients?
So, in Inland Empire's Health Information Exchange, we're also an opt-out. We found when we all got together, we decided that would be the fastest way to get information on the Health Information Exchange, because it would be very useless if we didn't have patients on. It would take us too long to get them enrolled. From a practical point of view in our practice, we've had a patient portal for over 4 years now, and so the patient's understanding of information being available to them has sort of developed over the last 4 years. And introducing the Health Information Exchange actually was quite simple. I think, as you had mentioned, there is a technical part to administer, especially for the ones who want to opt out. And so the EMR had to be configured in a way so that we are able to document when they opt out and be available on the Health Information Exchange. But I would say overall, the acceptance to the Health Information Exchange is very, very high. I agree. All patients say, well, yes, of course. You know, they expect that. When we explain to them that if they're in a massive accident and they're sitting at a hospital in Loma Linda and nobody's around to give them information, they definitely want their information to be available to the ER physician treating them at the place of care. So it's been pretty smooth.
So I read recently in a report that when it comes to malpractice, medical malpractice, the reason that patients file lawsuits is not so much because a mistake was made, but because providers weren't upfront about it. So do you think that that is kind of the key to building this trust, is just talking to patients and educating them and keeping them engaged? Are you finding that that's rather than just handing them a piece of paper and letting them know what's going on?
The patients and having the capability of embedding the consent, although I don't like to call it that, patient permission, on a patient portal and letting them see it and have control of it is very powerful. When a patient arrives at a doctor's office and you hand them yet another form and they just sign it, they really don't know what's behind that. But when they can view it, see it on a patient portal and feel like they have control of it, just as their bank account or anything else, then I think that that has the real power.
In our circumstance, because we are a specialty care providing organization, having the transparent communication, if you will, that an HIE affords. There was earlier discussion about delays in document distribution and such. So it really provides that more transparent, efficient care and communication methodology. So our patients are definitely expecting that referring provider is getting that information sooner and thus able to take care of them at the pediatrics provider level.
Good. So I want to spend a couple minutes talking about something that I've already heard a few times over the last 2 days, and that's sensitive health information and the need for, not only as what Becky talked about, patients to be more in control of their data, but specifically around sensitive health information. And one of the findings from the demonstration projects is that although some of our HIE participants and partners are exploring ways to incorporate behavioral health and other sensitive health information into the records, it really is still an all-in or all-out situation. And so I'm going to ask Vic to talk a little bit about what you're working on and how we can kind of move into, incorporating that information and maybe getting it down to more the need for more granular data.
It'd be my pleasure. First of all, we recognized real early that we were going to have major issues with relationship to trust, because historically, mental health patients, on whom I'm going to focus this morning, had historically been told by their psychiatrists and providers in the mental health system, we don't deal with the physical health portion of you. That's another part. So we were really excited when the Affordable Care Act passed for a number of reasons, but among the reasons was this concept of integrated primary care. So there we started to promote the concept of this, you're one person, your entire well-being should be important to your primary care physician. And when we looked at the bidirectional integrated primary care, we likewise said your entire well-being is going to be important to us now. And so we started promoting that information. We shared a lot of presentations. We did pilot projects where we placed psychiatrists and social workers in hospital clinics and David Culberson's outpatient family medicine clinics. We placed a psychiatrist in a FQHC and piloted that. And we did things like invite Lori Heck, who facilitated the first panel, to come and present to our Mental Health and Substance Abuse Board. And her presentation was very positively received. In the end, some patients actually approached me and said, it sort of sounds like a public Kaiser is what we're putting together in terms of our HIE. Because our HIE consists of primarily Medi-Cal and safety net providers. The county hospital, San Joaquin General Hospital, the health plan of San Joaquin, an FQHC, and behavioral health services. And we explained, yeah, that's the way we want to work, but we don't have any formal connections. We're not part of one organization, but we do have agreements to work together to do better, provide you better care, and to provide one another the information we need to provide you the best care, including the behavioral health services information. If you'd like, I can go into that now. Okay. So there are significant barriers to sharing information that's sensitive. Fortunately, we've had an electronic health record for, I think, 4+ years now, so we had a certain level of comfort with that. Even though none of the behavioral health electronic behavioral health records that are used by counties now include inpatient care, we were able to link with an e-prescribe provider called RxNT, and we connected that to our electronic health records so that upon discharge from inpatient care, the medications and diagnosis could be included into our own electronic health record. So we had a mini complete record. And we thought that was very important to us. And so as we began to look at implementing, so we had the electronic health record, we decided not to include the information that's prohibited through 42 CFR. Not prohibited, it's just very difficult. And that's the substance abuse services information. And to assure the sensitive information was limited to only what was needed, we've restricted the data elements that we'll be sharing into the HIE to no more than 5, basically demographics, diagnosis, medication, labs, and allergies. So there's no sensitive materials there in terms of narrative, stories being told, the confessions in some respect. So none of that is going to be included in the electronic health record. So we felt really good about that. Along the way, we did other things, like we established a partnership with our Consumer Advisory Council, we call our patients consumers, and our National Alliance for Mentally Ill, who are usually family members. We established an initiative partnership with them called the Consumer Health Empowerment Initiative. And that really helped to seal the deal, that we were really committed to providing them the entire full measure of care that they were needing, physical as well as emotional and mental. And they have taken that very much to heart. We've had, for instance, 3 wellness fairs or health fairs on our campus. So on a mental health campus, we had health fairs, and they've been very well attended. We've had delivered well over 300 flu shots, for instance, in the last couple of years. And that's important because part of what we focused on our initiative, our Consumer Health Empowerment Initiative on, was the reclaiming of life expectancy. The mentally ill, on average, live 25 years less than the rest of us, but they die from the same things: obesity, poor diet, lack of exercise, heart disease, diabetes, the same things that can be prevented many times. So they very much engaged, and to do something like deliver over 300 flu shots, I think is big, because the mentally ill are 5 times more likely to die of a respiratory illness, including pneumonia and influenza, as the average American. So we've been convincing. We think we've taken the proper steps. There is an additional level of confidentiality that we've inserted, as Richard Swafford indicated. And the way we're going to do that is we're going to approach each and every patient individually and ask them whether they want to participate in the HIE as we explain it to them. And we'll explain the 5 elements and the restrictiveness. And we've been told by our consumer patients that they want to participate. And if you stop and think of it, if the general public wants to participate in HIEs, and the mental health patient is a member of the general public, why would we expect otherwise? So I think it's going well for us.
Great, thank you. Dorothy, at Rady Children's Hospital, I know that minor consent is definitely an important issue. So can you talk a little bit about how Rady Children's Hospital is managing that sensitive category?
So although we typically would consent the parent, we have somewhat of a phased implementation, if you will, as far as the data sharing, what would be going across. So if the consent is I'm in, or actually we also consent I'm in, but only in the case of emergency. If that patient, so for example, we have a trauma counseling department in our child abuse department. The trauma counseling piece is a little more sensitive based on the patient's age and the information contained. Currently, we're not sending that data. So some of the adolescent medicine and reproductive health issues that are concerning, that's still information that emergency room provider would need to know. So in many cases, we would be sharing that information via the health information exchange, but potentially based on department and type of service that patient is encountering, that information would be filtered at the Rady Children's level until we're confident that the HIE has similar integration so that we are able to discreetly say yes to this data, no to this data. So in general, we are not consenting those patients differently than we would for a 5-year-old child, if you will. However, that patient also, if they're over that age, has the right to say, I want to opt out. I'm taking back my consent. We also do have an adolescent inpatient psychiatry unit, which is live with the EHR and came on board after we started going down the consent path. And although our opt-in consent does allow for, it communicates that I'm releasing or I'm allowing the sharing of my mental health information, we're still in the phased implementation of sharing that data. Again, we want to make sure that at the foundation level, that integration between our organization and the HIE is able to support appropriate restriction of the information.
Great. So I want to go back and talk a little bit about, so building trust with patients is critical, but as I've already heard once today, trust amongst providers and stakeholders within the HIE is also critical, and in some cases can be a barrier as well. So can each of you talk a little bit about how that issue has been dealt with in your organizations at the HIE level? How has the HIO fostered trust amongst the providers? And again, there's some competition. So how is the HIO and the governance, the internal governance, helping alleviate and build trust amongst providers? Dr. Mahdi, you want to start?
I think for the health information exchange, when we first started, I think the key was bringing everybody in to the table at the beginning. And as we developed, our board is actually representative of small groups, large groups, small hospitals, large hospitals, institutions, and having everybody at the table at the same time was critical in building the trust between the different entities. So that was really, I think, important building at the beginning. But I just wanted also to add on, just on the behavioral health too, and the health information exchange. I think we in the primary care, as physicians caring for a lot of patients, the behavioral part is critical for us to help take care of the medical problems of a lot of our patients. We have quite a large population of patients that are seeing psychiatrists, and we really don't have that information. And it really impedes us in helping care for those patients, whether they're diabetics or high blood pressure. So I think it's going to be very exciting as we go forward. Yeah.
We have the advantage of being in a fairly small community, and as I said earlier, we have a lot of physicians that are onboarded and participants of the HIE. So the peer pressure for the ones that are not, they have to answer to their colleagues. So that helps bring them to the table. And when their patients are going from the primary care to the specialist, that expectation that those records be there. And if they're not, they're on the phone saying, why are you not connected to the HIE? So they have to answer to their partners. And that makes, they don't want those paper charts. We've come a long way. We've been at this for a long time, and I go to these meetings and they're going, I am not going to go through a paper chart in the categories to find the information that I need. So they have a lot of answering to do amongst themselves, so that helps.
With the economic downturn, I think as safety net providers, we had more than enough patients. So there wasn't a lot of competition. But I think the element that brought us together foremost was we got together to view these webinars about the Affordable Care Act and that integrated primary care. And behavioral health actually hosted a number of those that were attended by the other three providers. And then collectively, we applied for a Blue Shield grant and were successful in obtaining that grant. So it's a significant grant, where we were able to hire a consultant from Colorado to come in. The consultant's name was Health Teamworks, to come in and help us develop our own ways for integrating the primary care services delivery. And so that was significant, and that we were together working on projects over a period of a couple of years. And I'd like to thank Richard again for that funding, because that really helped us come together and really overcome a lot of any competitive issues that may have arisen, but they weren't likely because at the time there just wasn't, we weren't competing for patients. We all had more than we could deal with.
At Rady Children's, we're a little different because we do take care of most of the children for specialty issues in San Diego. So our providers, there wasn't really a sense of competition, if you will. We are still waiting for our primary care group to finish consenting all of their patients. They're in a pilot state. We share our EHR with a primary care group of pediatricians, one patient, one master patient index ID, if you will, one medical record number. So I can't speak for those other hospitals in the organization. I will, within the HIE, if you will, I can say that they are watching and waiting to see what happens with us. We recently did have a group of community clinics that went live with the HIE in October, and that's exciting to have some primary care individuals now having access to our data. But I imagine we're no different than other cities and towns where there is some definite concern or worry. Will I lose patients or what? But we have plenty of patients to take care of.
Thank you. So I'd like to make sure that we have enough time for any questions out there. Great.
Tolerate that from them, I think will hopefully alleviate some of the cutting out on the audio.
I have a question for Dorothy. Working in a pediatric provider world, patients, actually parents likely not wanting to give the Social Security number for their child. How are you doing with patient matching within an HIE environment for your PEDS patients?
Thank you for asking that question. So when we started going down the road working with the HIE about 2 years ago, I recognized there wasn't an identity work group. There was a privacy and security work group, a technical work group, a clinical work group, but there wasn't an identity work group. And with everyone moving down the pike of their own EHR vendor, that also meant that there are multiple algorithms within our own organizations that match and find potential duplicates or help prevent overlays. So the question you're asking actually was a topic of conversation 2 weeks ago at American Health Information Association, and the challenges of, if I'm even allowed to say unique patient ID at this meeting, but we have an identity work group that has the identity experts from each organization collaborating and working through scenarios, cases, testing our different matching algorithms. It's brought to light the University of California, San Diego organization. What is their naming convention for babies versus what is our naming convention for babies? And going back at some level and looking at naming conventions, I have an apostrophe in my last name. I probably cause a lot of problems for a lot of different. Some organizations may remove the apostrophe and leave a space. Some may, you get what I'm trying to say. So it's really having conversations at the community level and coming up with additional standardization in how we are capturing the data in those discrete fields that could potentially cause a duplicate or an overlay. We don't want to have duplicates or overlays, so that identity team needs to be at the core of the conversation.
First, hello? Oh, Sorry. First, thank you for being willing to test this out and let us all get the benefit of going through it. My question is related to whether or not anybody has more information about, do patients, are they concerned about who is kind of walking them through the consent process? Did they have preferences? How did you all deliver the consent to the patient? And I know that there's talk about, have the provider do it, who's supposed to do the consent, and that that's somehow really important. Did you find that to be true?
We have it on the provider level, and we had 5 different offices in our pilot, so we had a kind of a combination of how they worked it out. We left it up to the provider and their workflows. But Karen and came out on site. It was Carrie. It was great, and we went around to the offices and we asked some of these questions. And depending on the offices, what we really found is that the form, we developed a form. We educated the front office staff and the office managers. The HIE did. We went out to all the offices and provided training. And then those office managers and front office staff trained within their own practices and facilities. So when the patient presented, they had the form at the desk and were told what it is. And again, in our environment, it was a little bit different because it was business as usual. So there wasn't a whole lot of questions. It was more of an expectation that, why do I have to sign a consent for this? It's a given. But those patients that did have questions, what we discovered was the form and the patient would then go into the rooms, and the MAs would help answer any further questions that they might have. And if they still were uncertain, and this was the surprising part to me, was the doctors would come in and give a scenario. If you don't opt in or sign this or agree to this, then when you go to your specialist, you're going to have to hand carry your records and your films, and it's not going to be the same seamless workflow that it is now. And if you forget those documents and you show up at your specialist, your care is delayed. So it was interesting, but most of the practices got it right at the front desk. And that's the administrative part that I was talking about earlier, is now we have a paper form that we have to deal with. So that either has to be scanned in and updated in the HIE, or I went around and personally picked up those forms and did data entry and did all the analytics on that. So that part needs some improvement, and we're getting there. But we had less than 0.5% opt out. So it was more of an expectation, and people are just expecting that their health care be available. I told Karen when I would be on the panel that I would do it from the perspective of the provider's office. And I ran a couple different provider offices, a radiology group and an orthopedic group. And the expectation that I found from the patients when they presented is we're the middleman in both those scenarios. And they were floored that they had to present their information again, and why didn't I have it? My doctor just sent me here. You should have gotten all that already from my doctor, and you should have that. So people are ready for this, and I think they're not as concerned as the privacy as we expect. They already know their banks work. HIPAA has been around for many years. I think they're comfortable with it.
Talk about the patients that had concerns. So can you talk a little bit about the process, going back to the question, and what the process is at your facility?
I think the consent is a big issue. I recently was in a hospital, had a procedure done. And I think I had like 20 pages to sign, and they gave me a little pad, and I had to sign here. And then I looked at the administrative person, and I said, well, what am I signing? And there was nothing to do with HIE, nothing to do with that. I think patient consent, when they come to our office, they consent for us to take care of them. If they don't sign, they don't. We can't provide them care. I think most patients, or all of our patients, really don't have a problem agreeing to be able to share the information. We already do that through our patient portal. So the patient portal actually is available to our specialists, so that if we send a patient to a specialist and her record or his record, there's a box that is clicked up so that the specialist at their office can open up the chart and see everything. So we sort of eliminated sending lots of notes that sometimes made no sense for them. So I think the consent form, I think if we explain it right, I don't think there's going to be any issues there. But I think there's a little bit more to do about consent than is really, we're making a bigger deal out of it.
Thank you. So I think we have time for maybe one more question, and I know we had one up here first. Sorry.
I have a question over here to your left, if that's okay.
Thank you. Terrific discussion. Thanks very much. My question has to do with, in California, under the California Medical Information Act, and I think there are also some terms in HIPAA, there are certain categories of information that are more protected than others. For example, reproductive information for minors and even for adults. Then there are special constraints on those types of information. I know in certain HIE efforts that has created some complexities. For example, the organizations participating in the HIE and contributing data are instructed, well, don't send us any data of these protected kinds. Make sure you filter that out before you send it to us, because there are special considerations that, for example, in an opt-out scenario, we cannot assume that patients want to share those information, and there are additional constraints on that per state law. My question, maybe this is particular to the opt-out participants here on the panel, but I'd also be interested in with respect to the opt-in category. Is that the case, that there are certain types of information that cannot be made available through HIEs under an opt-out scenario because of these constraints? And how is that being handled? And B, for the opt-in strategies, does that opt-in consent cover those special kinds of information as well, so they can be shared through the HIE? I hope that made sense.
Everyone. Well, I think in our, we're an opt-out, and there are certain levels of information that can be shared, and so the sensitive information, I think, which is the behavioral we're still working on, which is not being shared at this point. And
we're working on that with Bill and Approches on figuring out all those solutions. But there are capabilities that information feed into the HIE and filter out, so it's not viewable. You have to have a specified class, which I think Dorothy was talking about as well. So information can feed in, and unless you have you're from that particular facility or have that particular role, then it's not viewable.
From our part, we've been very conservative. As I've noted earlier, we're only including 5 data elements for the mentally ill. So I don't know that we have the concerns that are raised by this particular question.
And as I shared previously, some of the checks and balances we put into place, I will say that amongst the privacy work group and our clinical work group with San Diego Health Connect, there has been discussion about the standardization across the organizations that feed the information, that if I am that primary care physician, I want to know that all of my patients' information is available regardless of the type. So as we look to the future, and possibly through adding potential payer admission notification through the HIE, we're balancing the need for the clinician to be aware of all the information with what anyone can get, if you will. So definitely working closely to make sure that the checks and balances are in place to protect the patient's sensitive information.
Thank you.
Well, thank you. So our discussions so far this morning have continued to raise more questions than we have answers for. But this is truly an industry in its infancy. I can't remember who said that this morning, probably Rich, because he says things like that. But this afternoon, after lunch, we're going to, and Dorothy, I'm going to borrow what you said, we're going to get down more into understanding the why behind the what. Because we know what it is that we've been focused on for 4 years, and now that information has begun to move electronically, why are we doing this, and how do we begin to apply analytics to the data to learn the lessons that will change the healthcare environment as we go forward?